Cardiac tamponade is a life-threatening situation in which fluid within the pericardial cavity compresses the heart, preventing its filling during diastole. Normally, there could be a thin layer of fluid about 20 to 50 ml in the pericardial cavity. When fluid accumulates gradually in the pericardium due to a slow disease process, the parietal pericardium stretches to accommodate more fluid in the range of 500 ml. But rapid collection of fluid, as in the case of bleeding into the pericardial cavity, is less tolerated, and features of tamponade and hemodynamic collapse may develop with as little as 100 ml of pericardial fluid. Causes of cardiac tamponade. Any cause for rapid collection of fluid in the pericardial cavity can cause tamponade. By and large, malignant effusion is probably the most important cause of cardiac tamponade, with large collections of hemorrhagic pericardial effusion. Traumatic cardiac tamponade can occur with any injury involving the heart. Proximal aortic dissection can leak into the pericardial cavity and cause hemorrhagic pericardial effusion and tamponade. Tuberculous pericardial effusion can also cause cardiac tamponade, though less dramatic than in case of a hemorrhagic pericardial effusion. Tuberculous pericardial effusion can sometimes be hemorrhagic as well. Interventional procedure-related cardiac tamponade is now being managed in the cardiac catheterization laboratory in fair numbers. Coronary perfusion can occur during percutaneous interventions causing pericardial tamponade. Procedures involving atrial septal punctures like balloon mitral valvotomy and ablation of atrial fibrillation in left atrium carry a risk of cardiac perforation and tamponade. Even simple right heart catheterization can result in cardiac tamponade, especially when manipulating relatively stiff catheters at the vulnerable inferior vena cava right atrial junction. Cases are on record in which both temporary and permanent pacing leads have perforated the right ventricle. Temporary pacemaker leads are more likely to cause perforation as they are stiffer. Clinical findings. Beck's compression triad is a combination of hypotension, distended neck veins, and muffled heart sounds. Pulsus paradoxus is another classic finding. ECG showing electrical alternance in large pericardial effusion with a swinging heart. Alternating QRS voltage is very evident in V1. Low voltage QRS complexes are also seen. Alternance in P, QRS and T wave amplitudes is called as electrical alternance totalis or total electrical alternance, which is considered as diagnostic of large pericardial effusion. This echocardiogram shows the heart swinging in the pericardial cavity with large pericardial effusion. Classical sign of tamponade on echocardiography is the diastolic collapse of right atrium and right ventricle, which prevents adequate filling of the heart. Management of cardiac tamponade is by immediate pericardiocentesis. In an emergency situation, urgent bedside aspiration may be life-saving. Pericardiocentesis under fluoroscopic guidance is more often resorted to these days, unlike the direct bedside aspiration of the yesteryears. The pericardial space is usually approached from the subxiphoid route and standard Seldinger technique with initial needle puncture followed by guide wire introduction is usual. Once the guide wire position has been confirmed, an arterial sheath is introduced over the guide wire. A pigtail catheter introduced through the sheath is used for therapeutic pericardial aspiration. If recollection is expected, the pigtail can be left there in situ for a few days for follow-up bedside aspiration with all aseptic precautions. In case of large periprocedural hemorrhagic pericardial effusion, it is usual practice to auto-transfuse the blood drained into the circulation using a three-way adapter. This reduces the blood loss in an emergency and buys time while the patient is being shifted for surgical repair of the periprocedural perforation. Discussion on left ventricular cardiac tamponade. Usual manifestation of cardiac tamponade on echocardiography is diastolic collapse of right atrium and right ventricle. This is because right-sided chambers can be compressed with much lower intrapericardial pressures than the thicker left ventricle. Isolated LV cardiac tamponade can occur post-operatively due to loculated collections posterior to the left ventricle. Echocardiogram will show left ventricular diastolic compression without associated right ventricular or right atrial collapse. Another situation in which isolated left ventricular diastolic collapse occurring with circumferential pericardial effusion along with cor pulmonale has been reported by Kollapudi and colleagues. In this case, right ventricular collapse was possibly prevented by the severe pulmonary hypertension and right ventricular hypertrophy. The condition was noted in a case of connective tissue disorder with cor pulmonale. Left ventricular diastolic collapse can significantly affect left ventricular filling and cardiac output. The classic finding of cardiac tamponade, that is pulsus paradoxus, may be masked in left ventricular tamponade. An interesting case of left ventricular diastolic collapse and regional tamponade following cardiac surgery due to a large left pleural effusion without any pericardial effusion has also been described by Bilku and associates. In this case, tamponade occurred more than 2 weeks after the surgery, which was an elective aortic valve replacement. Another case series presented one case with left ventricular tamponade with post-cardiac surgery loculated pericardial effusion and another with severe pulmonary hypertension and circumferential pericardial effusion. The post-mitral valve replacement loculated pericardial effusion was drained from the axilla by echocardiographic and fluoroscopic guidance. As the pericardial effusion was circumferential in the second case, it was drained by the subxiphoid route. There was no paradoxical pulse in both cases. Jugular venous pressure was not elevated in the case with loculated posterior effusion. The patient with severe pulmonary hypertension had prominent CV wave in the jugular venous pulse due to severe tricuspid regurgitation. In regional left heart tamponade due to loculated effusion, right ventricle is free to expand in inspiration without interfering with left ventricular filling. This can explain the lack of pulsus paradoxus, which was shown by Schwartz and colleagues in an experimental study. Here are the first set of journal references. Second set of journal references are here. Thank you for watching this video. Please subscribe, like, share and post your valuable comment below this video.